So good morning, everybody, and welcome to our Open Disclosure Webinar. Thank you for joining, and to those of you who are avid followers of our webinars, apologies for the postponement in the last previously advertised date for the webinar in July, and we're very grateful for your patience, which will be rewarded today because we've assembled an expert panel for our webinar on the Patient Safety Act, which will focus today on the notifiable incidents. It is our third one in our Patient Safety Act webinar series. The previous two are available on YouTube, so please do refer back to them if you have any questions or you're seeking further detail on the Act and its implementation. Next slide, please. Just as I move through the housekeeping, I think it's probably important, the first thing that I say, that the notifiable incidents are set out in Schedule 1 of the Act, and the link to that can be found in the chat box. They are very rare incidents, circumstances, and very serious in nature, with 12 of the 13 resulting in patient death. So we do want to set out at this beginning point that the content of the forthcoming discussion could be unsettling, upsetting, and potentially difficult for some of our audience. But it will be very informative and highly engaging. So if you have questions, please use the chat box. The session will be recorded and later available again through our YouTube channel, and we ask that you leave your video off throughout, and your microphone will remain muted in that status throughout the webinar. Next slide, please. If you have any difficulty with your audio through WebEx throughout the webinar, you can see there dial-in details which might provide a better audio experience for you. And thank you so much. On this slide, you can see our CPD point information. Our webinar is accredited with the following CPD points when listening live. Applications for certification of those points is made through our email, and all inquiries we would ask also come to that email inbox, please. Thank you. We have two ISL interpreters supporting us today. We have Ella Chihotska and Sarah Falconer, to whom we're very grateful. Thank you. And equally, you will find that closed captions are available and may make this session more accessible to you. Thank you. Next slide. So on to our panelists. Our speakers today are Mr. Ken Mealy, the National Clinical Lead for Surgery, Dr. John Fitzsimons, Consultant Pediatrician and Clinical Director for Quality Improvement, Professor John Murphy, National Clinical Lead for Neonatology, and Georgina Cruz, National Manager of the Patient Advocacy Service. We were unable to secure maternity leads for today's session, but it is certainly something that we would want to give full detail and full expert insight into. So watch this space, and we will hopefully be coming back to that issue in the very near future. Thank you. I'm going to pass you over now to the Assistant National Director of Incident Management and Open Disclosure, Lorraine Schwamberg. Thanks, Lorraine.
Thank you, Ellie. Thank you, everyone, for joining us today for this notifiable incident session. And thank you, Ellie, for highlighting the caveat that they are very serious incidents and obviously yeah, just highlighting the sensitive nature of them. I'm just going to give you a little recap around the Patient Safety Act, which I'm sure you'll all be quite well versed in now, but for any person who's maybe joining us for the first time of 3 Patient Safety Act sessions. Next slide, please. So we know that this Patient Safety Act, the piece of legislation, was enacted last year, and it's meant to commence at some point this year. Now, we do feel that is imminent. We don't have an exact date of that yet, but we do feel that it will be very imminent, and certainly we're anticipating some information around that, which we will share with you as soon as we know. So overarchingly, the Act focuses on patient safety, in particular open disclosure. It introduces the legal and mandatory requirement around open disclosure for a specific list of incidents called notifiable incidents. So this is new language that you will be hearing over the next little while. There are currently 13 different notifiable incidents, and they have been set out in the Patient Safety Act, and that's what we're focusing on in this session today. The Minister does have the right to add to that list through regulation in the future. Where one of those notifiable incidents is identified, there is a requirement to notify the relevant regulator of the notifiable incident. So that's either HICWA, the Mental Health Commission, or the Chief Inspector. And that requirement is that we make that notification through the National Incident Management System. So we've been very busy working with colleagues in the State Claims Agency in particular, developing the technical functionality around that. Provided we follow the requirements of the legislation, any content that we disclose or the apology provided during the open disclosure under the Patient Safety Act for a notifiable incident is protected in legislation. The legislation also provides provisions for procedures in respect of clinical audit, in particular the data and how that data collated during clinical audit is protected. It makes amendments to the Health Act 2007 in relation to HICWA to carry out statutory investigations and an expansion of monitoring into private hospitals. So we know obviously this legislation is applicable to the private setting, not just the public setting for us here in the HSE. It introduces discretionary powers of the Chief Inspector to conduct a review of specified incidents that may have resulted in death or serious injury where some or all of the care was delivered in a designated centre, such as a nursing home. It does introduce amendments to Part 4 of the Civil Liability Amendment Act 2017, which obviously is where staff can seek voluntary can engage with this legislation and seek protections for content discussed in the apology for any Patient Safety Act, provided they follow the processes of the Civil Liability Amendment Act. And it introduces the mandatory communication by health service providers of reviews carried out in relation to cancer screening that were requested by the patient, and that's specific to breast, bowel, and cervical screening. But as we highlighted, this is specifically around the notifiable incidents this session. And Ellie did provide the caveat that obviously a number of the notifiable incidents are very obstetric maternity specific, and unfortunately we couldn't secure a representative to speak to those today, and we do require that expertise for the webinar purposes. So as Ellie said, watch this space. We will follow up on those discussions. Okay. Next slide, please. Next slide. So as some of you will know, we've done quite a few events and engagements with colleagues throughout the HSE, in particular with staff, and some of the key questions that keep coming back to us in terms of, well, what are our responsibilities? What are the requirements around the legislation? So we have a few slides just to set that out again here for you, okay? So apologies for the legal language that is used, but just to highlight to you some of the important sections of the legislation, okay? So a health practitioner to inform a health service provider of a notifiable incident. It's the responsibility of all our healthcare staff, health practitioners, that if in their opinion a notifiable incident has occurred in relation to a patient, the health practitioner shall, as soon as practicable, inform the health service provider, which is at the time he or she has formed the opinion, providing the health service to the patient. So the message from us has been very much that all our staff are required to report those types of incidents. We would obviously say that they need to report them through the NIM system, but local organisations will have their own means of escalating them quite promptly within their health service setting. Okay, next slide, please. The obligation to make an open disclosure of a notifiable incident. So where a health service provider is satisfied that a notifiable incident has occurred in the course of the provision by it of a health service to a patient, whether the notifiable incident occurred when that provider was providing that service or another health service provider was providing a health service to that patient, the health service provider shall, subject to a couple of the exemptions, which I'll touch on in a minute, hold a notifiable incident disclosure meeting in order to make the open disclosure of that notifiable incident to the patient or their relative, notwithstanding the absence of knowing some or all of the consequences of the notifiable incident or some or all of the information related to the notifiable incident. So that just highlights the requirement to make the open disclosure. There are a couple of scenarios outlined in the Act where you might not be able to facilitate the open disclosure. In one instance, the patient or their family might decline open disclosure at that time, but they do have the opportunity to avail of that over a 5-year period if they so wish. Or you might not be able to identify or contact the relative of the family, and for that reason you cannot do open disclosure. And what this section is also highlighting is that they are trying to encourage us to do open disclosure whilst we want to ascertain as much of the facts as we can. Obviously, at the outset, there's often a lot of information that we won't know, and we shouldn't delay open disclosure because we don't have all the information with regards to that, and we don't necessarily know the full impact of the incident. The next paragraph I think is important for everybody, and this is not written in the legislation, that this is the HSE interpretation, okay? So this Act speaks to where the health service provider is satisfied that a notifiable incident has occurred, okay? In the spirit of legislations, which is all about openness and transparency, the HSEs interpret this in the following way. Whilst there is a determination to be made if a notifiable incident occurred, it is not a requirement to establish this with absolute certainty in the legal sense or to determine a cause of death. Rather, reasonable assessment or clinical assessment should be made with the information available at that time on the likelihood that a notifiable incident occurred. Where it is deemed that a notifiable incident likely occurred, the healthcare practitioner and health service provider must take the required actions that I've touched on in part already. Okay, next slide, please. So making the open disclosure of a notifiable incident by a health service provider, the open disclosure of a notifiable incident should be made on behalf of the health service provider by the principal health practitioner in relation to the patient whom or in respect of whom the open disclosure of the notifiable incident is to be made, or where that principal health practitioner is not available or otherwise not in a position to make the open disclosure of the notifiable incident, or having had regard to the circumstances of the notifiable incident, the health service provider or the principal health practitioner is satisfied that the open disclosure of that notifiable incident should be made by another health practitioner. The open disclosure of that notifiable incident should be made by a health practitioner whom the health service provider identifies. Okay? So generally, and that has always been our open disclosure policy, it's the patient's consultant, the lead clinician looking after that patient who will make the open disclosure, and there may be some circumstances where the health service provider will identify an alternative clinician to do that. Okay, next slide, please. And then importantly, obviously, the legislation introduces the requirement to notify the regulator. So our responsibilities around open disclosure, having the meetings, and our responsibility in terms of letting our informing our regulators. So where a health service provider is satisfied that a notifiable incident has occurred in the course of the provision by the health service provider of a health service to a patient, it shall notify the relevant regulator of that notifiable incident as soon as practicable, and in any event no later than 7 calendar days from the day on which the provider was satisfied the incident had occurred. And then the legislation describes it a little bit further in terms of what regulator needs to be contacted, and certainly our regulatory colleagues will be providing some guidance, and they're working on that at the moment. So where a health service provider carries on the business of a designated centre and is satisfied that a notifiable incident occurred, it shall notify the Chief Inspector of Social Services. A health service provider which provides a health service in an approved centre is satisfied that a notifiable incident has occurred, they will inform the Mental Health Commission. where a health service provider carries on the business other than that of a designated centre or approved centre, and it is satisfied that a notifiable incident occurred, then it will be HICRA who will be notified. Okay, and as I mentioned already, that will be through the NIM system, and then the regulator will acknowledge receipt of that notification within 21 calendar days. And again, the legislation outlines what information we need to share with the regulator, and the NIM system is being built so that it captures exactly the requirements of the legislation. All right. So that's just to set the scene a little bit. But now we're going to move on to, I suppose, the interesting piece, which is the discussion around the notifiable incidents. And I'm very grateful to be joined at the initial stages by Mr. Ken Mealy. Oh, I can't see the slides at the moment. Thank you, Naomi. I can see them again now. Ken, do you want to just introduce yourself?
Morning, everyone. My name is Ken Gathered. I'm a general surgeon and I'm co-lead in the National Clinical Programme in Surgery.
Thank you. We're very grateful, and you have been joining some of our working groups in terms of the implementation around this legislation. So next slide, please. I suppose for me, before we jump to Ken, there are a couple of definitions that are used repeatedly for all the notifiable incidents throughout the Schedule 1, and that is the reference to an unintended and unanticipated death, where death did not arise from or was a consequence of an illness or an underlying condition. So as Ellie highlighted, they are very serious incidents. Predominantly, we are dealing with patient death, which obviously is very significant and traumatic for all those involved. So the Act does define unintended in relation to a death means a death arising from an unintended event occurring or arising from the provision of a health service. Unanticipated death is not defined in the Act, but understood to mean that where there was a death other than an anticipated or expected death, or a death where there was no expectation that the person was likely to die in the manner or at the time in which they did. And then at the, towards the end, then generally they do make reference to the notifiable incident not being directly linked, or the death not being directly linked to any underlying disease, which is probably a bit more self-explanatory, but this is referenced throughout. So next slide, please. So the surgery-related incidents. Next slide. So there are 5, and you see in the notifiable incidents list in the schedule, they are numbered 1.1 up to 1.12, and then the last one is listed as 2.1. So the first one relates to surgery performed on the wrong patient, resulting in unintended and unanticipated death, which did not arise from or was a consequence of an illness or an underlying condition of the patient, or having regard to any such illness or underlying condition, and was not wholly attributed to that illness. So we understand from this definition that there was surgery or surgical intervention. The procedure was on the wrong patient. It resulted in an unintended and unanticipated death and was not attributable to the patient's underlying illness. So Ken, I suppose from your experience, they do refer to surgical interventions and surgery. What does this tell us, I suppose, generally around those notifiable incidents? What might be surgical interventions?
Well, I think it's worthwhile just flagging that it's a little bit broader than just surgery. Any invasive procedure, so anesthetic procedures where you put in central lines, radiological procedures, interventional radiology, dental procedures, all of these are invasive procedures, and we would assume that all of these are included within this definition. Wrong patients is clearly a adverse incident, and it's notifiable here in the context of when a patient dies. And one might think that this should never happen or can't happen, but it can happen, particularly if you have patients in a hospital, in a ward, on a theatre list, for instance, that have the same name. So it is a real issue and something that we all need to be aware of.
Thank you. Yeah, and I suppose that's the underarching principle, isn't it? That's trying to further embed patient safety so that we kind of understand the underlying contributory factors and get the learning from any such incidents. So the next one relates to surgery performed on the wrong site, resulting in unintended and unanticipated death, which did not arise from or was a consequence of an illness or an underlying condition or the patient, or having regard to any such illness or underlying condition, and was not wholly attributable to that illness. Similarly to the other one, there was surgery or a surgical intervention that resulted in an unanticipated and unintended death and was not attributable to the patient's underlying illness, but here was performed on the wrong site. What would that maybe mean? Or
so I think we see this rarely, thankfully, in various situations. Orthopedic procedures in particular lend themselves to it. So surgery of the spine, if you get the wrong segment of the spine in terms of disc surgery, for instance, that may lead to one of these instances. We're symmetrical individuals, so it's not unheard of for the wrong hip or the wrong knee to be operated on, or the wrong site in terms of a hernia repair, a kidney being removed. So while these are very rare, they can occur. And of course, in many cases, patients don't die, but clearly if they do die in the context of this act, these are notifiable events.
yeah, and I think just thinking about that, you have been very helpful in terms of working up some of the guidance and that. And we really struggled to come up with some example where there was an associated patient death, and thankfully they are rare, and there are lots of steps that I think very much led by the surgical nursing and anaesthetic professions that kind of have put in barriers to prevent those types of incidents, which is why they're rare, but even more rare to see an associated death with those incidents. So the next one relates to wrong surgical procedure performed on a patient, resulting in unintended and unanticipated death. So written similarly to the aforementioned notifiable incidents, the difference here being that there was a wrong surgical procedure. What would that mean, I suppose, in the context of kind of
So I
health
think
service?
So I think you could see this in different scenarios within surgery, where perhaps a patient has a lumpectomy or a mastectomy rather than the other in terms of breast surgery, wrong procedure, perianal procedures, patients consenting for a hemorrhoid operation, but then ending up having an operation on the anal sphincter, where consent has not been appropriately attained. These will be examples of the wrong procedure. Now, again, thankfully, most patients would not die as a consequence of these operations. But if you were to get a serious post-operative complication, such as a pulmonary embolus and die, these clearly would be notifiable incidents in the context of the act.
Thank you. Next slide, Naomi. Thank you. So the 1.4 notifiable incident is where there's an unintended retention of a foreign object in a patient after surgery, resulting in an unanticipated death which did not arise from or was a consequence of an illness or an underlying condition of the patient, or having regard to any such illness or underlying condition was not wholly attributable to that illness. So again, there was surgery, surgical intervention. In this scenario, there was an unintended retained foreign object. And you think of what, I suppose, what's the relevance here around unintended retained foreign object? What do they mean? What's meant here?
We tend to hear of retained foreign objects because they usually end up in medical legal incidences. The ones that are particularly problematic are when instruments or swabs, and particularly swabs, are left in the abdominal cavity and need to be removed because they will frequently give rise to symptoms. So a scenario in which a patient has to undergo a laparotomy to remove an instrument or swab and then dies as a consequence of that operation, again, due to sepsis or due to damage to some other organ or due to a pulmonary embolus again, these would be notifiable incidences and are conceivable in the context of remedying the solution of a foreign body can be quite serious.
Thank you. Okay, then lastly, 1.5. So this is slightly different. So where there wasn't any unintended and unanticipated death occurring in an otherwise healthy patient undergoing elective surgery in any place or premises in which a health service provider provides a health service where the death is directly related to a surgical operation or anesthesia, so including recovery from the effects of anesthesia, and the death did not arise from or was a consequence of or wholly attributable to the illness or the patient or an underlying condition of the patient. So again, we know there was an unintended and unanticipated death. It was directly related to surgery, surgical intervention, or indeed anesthesia. It was elective surgery that took place in where we provided a health service, and the death was not attributable to the patient's underlying illness. Now we know from the legislation that otherwise healthy patient is not defined in the Act, but through engagements with various colleagues and certainly with yourself, Ken, and Denise, they shared with us, I suppose, some way of interpretation, which is the use of the American Society of Anesthesia, the ASA score. Can you explain that, or how would you interpret an otherwise healthy patient?
So we look upon it, and we look upon ASA scores 1 and 2 as being essentially healthy patients. ASA 1 is defined as a healthy patient with no particular health issues. ASA 2 is defined as a patient with a mild disease which has no immediate medical consequences for those patients. So the patients who are classified as ASA 1 and ASA 2, and all patients undergoing surgery by an anaesthetist with a general anaesthetic by anaesthetist would be classified as ASA 1 to 5. So ASA 1 and 2, if a patient were to die after an operation and they were classified as ASA 1 and ASA 2, they would be it would be completely unexpected and maybe due to iatrogenic injury to another organ. It may be due to sepsis. It may be due to some unanticipated medical event. But these clearly are classified within the notifiable incidents. And of the 5 surgical instances, I believe this is probably going to be the most common one that may arise in terms of needing to be notified.
Oh, thank you. That's really helpful. And as I've touched on, I suppose we are developing some guidance and examples and e-learning programs for our staff. And I think over the next little while, certainly once the Act commences, we'll see incidents being reported that will really inform, I suppose, our insight into how the Act should be interpreted. But you're staying on for the discussion, and certainly if colleagues have submitted questions into the chat, we might bring them to you as part of the panel discussion. Thank you so much, Ken. Very grateful.
Thanks, Ryan.
Okay. Next slide, please. And I am very grateful to be joined by Dr. John Fitzsimons. John, do you want to just introduce yourself?
Yeah, sure. Good morning, Lorraine, and thanks for having me here. Yeah, I'm a pediatrician. I work at CHI in Temple Street, and I also work with the RCPI and with NQPS as a clinical director for quality improvement. And I'm particularly interested in patient safety, and I think this is an important part of improving patient safety.
Thank you, John. Okay, so these next instance we've kind of clustered together as generic incidents because I think we feel that they could apply in quite a vast number of settings, and even the surgery ones that we touched on earlier, they can occur in any specialty. Even though we've called them surgery, they could be in any of our surgeries, predominantly in nearly all our specialties. So even though we've clustered them in part, I suppose it's just for everyone to recognise that they are broadly applicable to a vast number of our services. So the first one that we've started here with is probably one of the more interesting ones in terms of interpretation. So any in unintended and unanticipated death occurring in any place or premises in which a health service provider provides a health service that is directly related to any medical treatment, and the death did not arise from or was a consequence of or wholly attributable to the illness of the patient or an underlying condition of the patient. So we know from the description that there was, for the notifiable incident under this legislation to trigger, there would have been an unintended and unanticipated death. The death occurred in any place or premises where the health service provider provides a health service. The death was not attributed to the patient's underlying illness. That again, in the legislation, there is no definition as to medical treatment. We have a reference there to our own HSE consent policy where treatment is defined. But what's your interpretation, or what's your thinking, I suppose, as a clinician when you read that notifiable incident?
Yeah, I think it is so broad, and it really encompasses really everything. And that definition of treatment from the consent policy again is so broad. You know, that therapeutic, preventative, diagnostic, palliative, you know, and related to any other purpose as well, you know, to the physical or mental health of the person. So it's incredibly broad. So I think it really encompasses lots and lots of different things. I think the key thing is that that bottom line there, you know, that the death is directly attributable to this incident, and that it's not attributable to the patient's underlying illness. And I think, I suppose, you know, from a clinician's point of view, I think it's when do I think, you know, that this is going to be or might be a notifiable incident. And I think, you know, obviously if it's unintended or unanticipated, that should be immediately, I suppose, asking questions. If it's associated, I think, with a procedure that's known, you know, to have a risk, you know, of an adverse outcome, including death. And then I think if there's known, if there's a known error, I think that has happened around that procedure, then I think those are all things that would certainly, you know, make you concerned that this is a notifiable incident. But I think that uncertainty will often remain. I think there may be, I think there will be many cases probably where a notified incident is made before any, you know, investigation or under kind of deeper understanding comes. So that, you know, things might change ultimately, but I think at the beginning, I think that a notifiable incident might be warranted at that point, and that needs to be communicated, obviously, to everybody involved, most especially to family.
Yeah, and exactly, you touched on it there in the early days. We do feel that there probably will be over-reporting.
Yeah, I think you'd expect that, wouldn't you? You know, that in one sense, if there wasn't over-reporting, then you'd be concerned of under-reporting. So, you know, there probably needs to be over-reporting, and I think there will be a learning phase. But I think there would always be over-reporting because things will only become clear afterwards. And again, I think that the act says, you know, that it needs to be directly related. You know, that's a very difficult thing to know in the immediate sense. You know, was this directly related, or was it a contribution? Was it, you know, what was the degree to which your concern might have been part of that?
Yeah. And I know even from the assisted decision making milestone after it's kind of commenced that there's a lot of learning still coming through, and I think we expect the same with the legislation, of course. Can you think of any examples possibly that might, or any from your patient safety experience, any kind of incidents that might have fit into this category?
Yeah, I think again those things where you know, death is not or an adverse outcome is not anticipated, you know, that immediately should, I suppose, raise the question, you know, has something happened that shouldn't have happened, you know, that a process that's usually meant to be safe has not been safe. So I think that unintended part or unexpected part, I think if it is recognized, this is something that is associated with the risk, although you can perhaps modify or significantly reduce that risk. And then if it's known that there was an error in that particular procedure. So I think removing a central line and somebody has a death occurs, shortly after the removal of a central line, that would lead someone to be concerned that perhaps that there's been an air embolus and something, an error in the procedure, the process, and again, I think that would be one. I think the placement of a nasogastric tube and where feeding has been started and there's a sudden deterioration and perhaps death. Again, that would raise the question, has there been a problem with the placement of something like that tube? Has there been a problem with the process in terms of ensuring it's in the right place before use? So I think there are certain circumstances that should certainly raise your level of concern, and I think justify making a notification. And nobody's going to get into trouble or I think find difficulty in a notification that ultimately turns out that it wasn't as the result of an error or an injury.
Perfect. Thank you, John. That was very insightful. The next one, 1.7, patient death due to transfusion of AVO incompatible blood or blood transfusion blood components, and the death was unintended and unanticipated, which did not arise from or was a consequence of or wholly attributable to the illness of the patient or an underlying condition. So again, we know the circumstances associated with the death, and here was related to the blood transfusion. For you as a clinician, any thoughts on that notifiable incident?
Look, happy to say it. This, blood transfusion in Ireland is a highly reliable and a highly safe process, and I think it has, many years of being like that. There are really robust procedures, pathways, guidelines, and designated persons, I think, around this. So I think that's very clearly something we're already, I think, aware of, that the risks of this, and that's why it's become so safe. So I think that's probably not going to be very little difference between that and existing practice. I think people would know if there is a reaction in the presence of a transfusion, that is reported and in this case now notified.
Thank you. And then patient death associated with a medication error, and the death was unintended and unanticipated as it did not arise from or was a consequence of the underlying illness. So again, we know the circumstances that there was an unintended and unanticipated death, but there was a medication incident. Again, more straightforward in terms of interpretation.
Yeah, I think so. Again, it's specifically related to medication. I think, again, where something has happened unexpectedly, where in particular, maybe a medication has been used that is known, that medication is associated with risk of an adverse outcome or potentially death, and then I suppose particularly where there's known to have been a medication error, all of those things I think would be indications that a notifiable incident has happened and should be made. I think it's interesting here. I think from the patient safety point of view, a lot of these notifiable incidents are very kind of much weighted towards acts of commission. So things that are done that result in an adverse outcome. But we also need to be aware of acts of omission, where things aren't done, and I think, while the act is there, I think, to improve patient safety, I think we also need just to be aware of reporting separate to that, and in particular around acts of omission, things that are not done, and because again, the direct relationship is maybe less clear there, but they're really important from the point of view of learning, from the point of view of creating, gathering good data on harm events, understanding kind of why harm happens and the things that we need to address in terms of safety. So I think the act will be a big contribution to that, but I think we need to be still reporting and aware that certain things won't fall under that.
Yeah, no, and particularly with the medication incident, we know obviously there can be significant harm if patients or service users are not receiving essential medication. So yeah, thank you, John. That was really helpful as well. And thank you also for staying on for the panel discussion. Okay, we might move on to the next slide. Yeah, so in this, our dear colleagues from the Mental Health Commission were going to join us, but unfortunately had to give their apologies. But we are, Ellie and I suppose we've had quite a few engagements with colleagues around the interpretation of this particular notifiable instance. So we did feel that we could speak to this and share some insight with you. And obviously anything specifically clinically or whatever, we will take away and follow up on any queries that might arise as part of the discussion. So we might go on to the next slide, Naomi. Thank you. So again, very sad incident. So where there was an incident where there was an unintended death, where the cause is believed to be the suicide of a patient while being cared for in or at a place or premises in which a health service provider provides a health service, whether or not the death was anticipated or arose from or was wholly or partially attributable to the illness or underlying condition of the patient. So there are a number of considerations here. Ellie, do you want to give us some insight into, I suppose, the guidance that we've had over the last little while?
Yeah, thank you. So one query that has been raised with us and that we had ourselves in relation to this notifiable incident is the terminology while being cared for in or at a place or premises in which a health service provider provides a health service. And the query is related to what exactly does this mean as we care for people in many varied settings. Through our work with the department and regulators, there is a consensus that to trigger the Patient Safety Act, the notifiable incident must have occurred on one of our sites, be it the acute setting or a designated centre or approved centre. It does not include incidents while a person is on approved leave from one of those centres, although it is important to note that it is likely that the incident will still need to be reported to the regulator under their other reporting requirements. Any existing reporting requirements to the regulator will not change with the introduction of the Patient Safety Act. We're mindful also, following our many engagements with staff and services, that there's been a position that health service providers do not determine if there has been a suicide, and that is the role of the coroner to make that determination. However, the language used in the Patient Safety Act for this notifiable incident is that the cause of death is believed to be by suicide, and referring to the cause of death in this way, in line with the legislation, is accepted. Thank you.
Yeah, so we'll never refer to the cause itself, but I suppose just referencing this notifiable incident is the key piece. I know many of our colleagues have been, I suppose, guided and informed that it's not language that we would use when we talk about incidents, but it is the language of this legislation. But the bottom line is the coroner makes that determination, which is why that kind of opening statement that I gave in kind of making that determination whether it is a notifiable incident or not, we do that for the purpose of openness and transparency, but not to provide a legal position or determine a cause of death. It's really, really important. And I think you touched on a few other points there as well. With any of these notifiable incidents, it is around the Patient Safety Act and our legal requirements and obligations around open disclosure and notifying the regulator. But while some of these incidents don't meet the criteria of a specific notifiable incident, they may still be an incident, a serious incident. There may still be reasons for doing system analysis review, to ascertain the learning, to partake in open disclosure, certainly where there's a death, to have good communication with the family, and so forth. So not to forget those really, really important pieces that we've been driving across the HSE over the last while. Okay, thank you, Ellie. Well done. And next slide, please. Notifiable incident 2.1. So incidents related to therapeutic hypothermia. I think I'm joined by John, Dr. John Murphy at this point. Next slide, please. John, do you want to introduce yourself? I can't hear John at the moment. I'm figuring from Ella that she also, there's no audio.
John's had some issues himself with technology, I'm afraid. He was having to log back in. So I could see him briefly then, but unfortunately his video seems to have gone and potentially he can't hear us, I'm afraid.
That's okay. I suppose I'll read this out, and I just see a query there from Noreen Russell. So we're not going to discuss 1.9, 1.10, and 1.11 today because we weren't able to secure presenters to talk to those. And there are, I know they are very maternity based, and there are definitely questions that are coming or from the wider system in terms of interpreting them, in particular, what's a perinatal death, what's stillbirth, what's meant by prescribed gestational age and prescribed gestational weight. And we are still working through that, I'm sorry to say, across the wider system. So from a regulator perspective and engaging with the department on that. So we didn't feel it was suitable to, I suppose, go through them today without giving you any determined answers to those very, very important questions. John, are you back with us? Ellie, do you want to just make sure that John maybe has the phone dial-in details as well?
I'm just doing that now, Lorraine. Sorry, 1 second.
Great. I always love our technical challenges on these webinars. So but just if you want to go back, Naomi, I just was outline some of this particular notifiable incident. So this relates to a baby who, in the clinical judgment of the treating health practitioner, requires or is referred for therapeutic hypothermia, or has been considered for but did not undergo therapeutic hypothermia as, in the clinical judgment of the health practitioner, such therapy was contraindicated due to the severity of the presenting condition. So that's an important distinction to make. So we know that this is very specific in terms of therapeutic hypothermia, which John was going to explain to us in a few minutes. And in terms of how clinicians make that determination that may warrant this notification.
John is working hard to come into the call now via the telephone. So hopefully he will join with us very shortly. Sorry to jump across you there, Lorraine.
No, that's perfect. Sure. While John is doing that, because it is the last notifiable incident, maybe we can even just open the floor to our panel and come back to John on this one in a few minutes, if that's okay. We're very grateful to be joined by Georgina Cruz today as well from the Patient Advocacy Service. And I was going to hand over to Ellie at this point to, I suppose, manage the chat box and direct some of the questions that have been coming forward. I think everyone could join the panel now at this stage, including Ken and John Fitzsimons.
Thanks, Lorraine, and thank you, panelists and those that have been speaking, and Georgia, sorry. We have had a question, and it goes, as a patient advocacy service, what do you see as the most important aspects of the Patient Safety Act in relation to open disclosure?
Yeah, hi, thank you for having us here. I suppose there's a few important aspects in relation to the Patient Safety Act. I suppose one of them is the mandatory obligation and the clear framework that's been put in place for the open disclosure process. I suppose it puts that obligation to make an open disclosure of notifiable incidents that have been discussed here earlier, and in that timely manner. It also lays out the clear process for the open disclosure, and that provides the opportunity for an apology or a disclosure of an incident or clarity around the next steps. And I think with this legislation, it will bring about that opportunity for consistency of application of open disclosure across the services. You know, it's there to support that ongoing, I suppose, cultural change towards that open and transparent health and social care system in relation to patient safety incidents. You know, although the HSE do have a robust open disclosure policy, we've seen in the work that we do that there are those inconsistencies around application of the policy. And I think this legislation, along with the HSE policy and the open disclosure framework, mark a very kind of important commitment to making open disclosure really a reality in practice. And it is important, you know, the documentation around the open disclosure for incidents to provide that opportunity has been discussed before for that learning and the policy development purposes. And I suppose from a patient point of view, like open disclosure really does put the person or the relevant person impacted at the centre of the process, and it strengthens their rights. The reality is there will be an impact and there will be harm as a result of patient safety incidents, and that those relevant people and people that are impacted are entitled to that open, honest and compassionate communication, and in a timely manner. And you know, they're entitled to that explanation, to be fully informed around the facts, you know, surrounding the patient safety incidents, what the consequences are going to be, and for that to be an ongoing communication in relation to further facts that might emerge over time. You know, I think as well, the designated person mentioned within the Act is really important. So the relevant person has somebody to engage with throughout the process. I know learning was brought up earlier. You know, the WHO, their Global Patient Safety Action Plan, it does highlight the importance of engaging patients and families as partners in care and keeping them at the centre of the process. And I think this mandatory open disclosure plays a huge role in that engagement of patients and families as partners. You know, it empowers the person, it builds that trust and that ongoing collaborative working relationships so people can share their lived experience and, you know, generate that data to inform that learning improvement. You know, what we see across our work with people impacted by patient safety incidents is that they want that improvement so it doesn't happen to other people. So I think it is vital that people are listened to and the policy and the legislation is implemented properly, and there's that clear communication between the clinical, you know, the quality, the communication side, you know, and it is about that prevention or reoccurrence of the incidents. You know, the designated person within the legislation will have a very important role, like that it will be a key link between the services and the service users, and it will be, I suppose, the key element that will build on that open, honest and transparent communication. And that it is really important about advising them of where to go, any follow-ups, you know, making the clinical language easier, being mindful of, I suppose, key dates like anniversaries and that. And even that initial open disclosure meeting, you know, the when it takes place, the environment it takes place, having the right people present, the communication and language within and around these meetings. These are all things that have big impacts when somebody's been impacted by harm. You don't want to compound that harm. You know, it's listening to the concerns of the relevant person, you know, the follow-up again to those meetings, which is described within the legislation, you know, the records, the minuted sent out. It's really important in that. And what we've found a lot in our work when we support people in the aftermath of patient safety incidents and around complaint issues, where at the moment we're in acute hospitals and nursing homes, and that communication is really key. It can alleviate compounded harm, and it does go a huge step towards building those trust and on those ongoing relationships. So I think the open disclosure really does mark the continuation of the shift in the culture towards that clear, empathetic, open and transparent communication. And that's important for the staff as well. You know, and it is around those factual explanations, listening to the story, demonstrating that empathy, the apology or regret, expression of regret if it's needed, the shared decision making in the ongoing care, you know, opportunity for a relevant person to raise concerns or ask questions, you know, so it is a huge part of the legislation. And just in relation to independent supports, I suppose we are an independent advocacy service. And while it's not mentioned in the Patient Safety Act, it is stated in the open disclosure framework, and we are ourselves highlighted as a support in acute hospitals and nursing homes. And I think, as has been discussed, the implementation of this Act will throw up curveballs through this learning phase, and it will be important that all parties understand those processes and the possible scenarios and consequences. You know, an example was given where you might report something as a notifiable incident, and then if it isn't one, how would that impact on the families and, you know, the relevant people or the people impacted. So that's where that independent advocacy can really help, because you've got somebody who's removed from the emotional impact of the situation. They have knowledge of the legislation, the terms, the patient safety terms, open disclosure, you know, and you can empower the person and keep them at the center of the process, you know. And as well as that, the advocate will be aware of what's required during the process and the policy, you know, and the rights of the person involved, you know, their right to know what went wrong, what's, you know, information on their healthcare, their next steps if it's relevant, and the right to be involved in the next steps and the sharing of the decision making. So that's what we kind of see as the important aspects from a patient point of view.
Thank you so much. And I think that's really important with what we might throw to now, because I can see Professor Murphy, John Murphy has joined us. So Lorraine, I might hand back over to you, because that hugely complex area is exacerbated, it is compounded, if you will, in the therapeutic hypothermia notifiable incidents. So we have a chat hopefully with our expert on that matter. Lorraine?
Yeah, thank you, Ellie. I suppose just to pick up on a few of Georgina's very powerful words, they're just really putting the patient voice forward again, and the patient advocacy service do play such an important role in kind of bridging some of our conversations. And there might be those tricky scenarios, you know, is this a notifiable incident, is it not? And I know one of the questions in this chat pointed to that as well. So, you know, it might be that the patient advocacy service can bridge some of those conversations. It's not just the health service saying, no, this doesn't meet that, but we are still being open and transparent and giving you all the information in terms of the care, the risks and the, sometimes sad outcomes associated with those. It's all about good two-way communication, being informed. And I know our regulators obviously are available for any patients or family members who feel that, you know, there are instances where we might not have gotten it right, or there was a notifiable incident, and you know, there might be some different views. But I think the other point that you touched on is really important, is that the general support. So one of the real positives of the Act that we obviously see is that they have made it a legal requirement for the designated person, whose main role is obviously to support patients and their family throughout the whole open disclosure process. So that's really quite positive. And yeah, it's again, very grateful for all your input, Georgina, there, and continuing to kind of engage with the health service around these important issues. John, we're grateful. It's always a bit nerving, isn't it, when the technical side challenges us a little bit. Naomi, are you okay to share just the slide around the notifiable incidents we're going to discuss with John? John, do you want to introduce yourself? Can you hear us okay, John?
I fear we may have lost John again.
Oh, we're really jinxed. We'll have to bring John back when we look at the maternity obstetric side of things. I think, well, yeah, we've come to the hour mark, so we might just close out the session. I know John's been very patient with us as well as much as we have been with our attendees today. Ellie, were there any other questions from the chat?
There were just a couple of questions. Ken, if I may direct the first one at yourself, it's says, does notifiable incident 1.5, so that is the one that relates to a unanticipated unexpected death after elective surgery. Does that notifiable incident specifically refer to patients who die during surgery, or if they die after the operation? What is the time frame for this death to occur?
I don't think there is a time frame, so I think it could relate to death during surgery or afterwards as a consequence of an operation. Now, death during surgery is extremely rare under any circumstance in this day and age, particularly for elective surgery, but it is conceivable. Damage to a blood vessel, for instance, or a major anesthetic catastrophe could lead to an unexpected death during surgery, and obviously complications, damage to other organs, blood loss, sepsis would be causes of death following surgery. And again, remembering these are ASA 1 and 2 patients. These are healthy patients where there is no expectation that they're going to die.
Thank you. That's it's good that you touch on that, because the next question does relate to ASA scores.
Ellie, can I just come in on that as well? Sorry, I think what's really important for us, there is no time frame associated with the death. It refers to the death occurring in our healthcare premises. So in particular, if we have patients maybe discharged from the acute setting to the community setting, even colleagues working in community, just to be mindful of patient if a death is linked to the surgery or if there's a complication, that it might still trigger this notifiable incident. So again, I suppose just removing the boundaries between different healthcare facilities and how obviously being mindful of the transfer of care between patients, between different services and that. And again, as Ken said, there is no time frame associated with it.
Thanks. So the next question, as I say, is somewhat related. Says, can I ask the panel for advice on a death when a death occurs that the family feel was not anticipated, but the medical team feel it was a potential outcome, i.e. the death in a patient with an ASA of 3 and a BMI greater than 40?
Well, that clearly is a scenario where patients would have a significant risk. And while it may not be notifiable within the context of the Patient Safety Act, an unexpected death would be reported through the NIMS system, and any patients and families who have concerns regarding any case can go through the appropriate risk management offices of any hospital or health sector or agency within the health service. So it does not, just because it may not be notifiable, does not preclude a family from pursuing an adverse event which they have concerns about.
Thank you.
I think in the early stages, we'll be engaging with our regulators in that quite a bit as well. You know, if there are any incidents where there is ambiguity in that, I think those doors would be open to us as well. We would think.
I think there's a very good question here about the guidance on the role of the designated person, the designated liaison person, and that might help us build into some of our promotional materials that we have at the end of every webinar. But we might just pause before we speak to the answer on that question to thank our panel. And indeed, the panelists that couldn't be a part of the conversation today. Thank you, John in his absence, and Ken and Georgina. Thank you so much for your time today and for your contribution, and for answering the questions from our callers, or our audience rather. Lorraine, I'll hand to you just if you want to give any special messages there.
Oh no, you've summed it up nicely. You know, much gratitude to our panelists today. I know you're all busy clinicians and busy in your different roles that you partake, so we're very grateful. We obviously in the National Office want to help colleagues out in the system in terms of implementation. We have those regular engagements with the department and the regulators where we can bring some of our queries forward. So don't hesitate to contact us if even after the webinar you think of any kind of scenario or something that you might be concerned about or where you would just like some guidance. John, we came to the conclusion that we might invite you back again for a third time lucky when we maybe work on the maternity pieces, because we know there's a lot of appetite in that. So once we can share some more insight into that, we might touch on Notifiable Incident 2.1 again. I hope that's okay with you. And I suppose big thank you to me from me to Ellie and the team as well, and our interpreters for joining us today. We have a few closing slides which we might just share. Was there any last thoughts from our panel before we cut into our promotional pieces? Ken, John, or Georgina, or John? That's great, thank you. So as you know, we are preparing for commencement of the legislation we feel is imminent. We are developing a number of resources with regards to that. We do have an e-learning program on the Patient Safety Act, which is very close to go live, so we will be sending out comms with regards to that. It'll be available before the end of the month, and various other resources, so watch this space. We had been doing a roadshow where we visited different services and sites as well, and we will, if we haven't come to you or visited you yet or presented on the Act to you, don't hesitate to get in touch. We'd be very happy to do that in the near future. Next slide, please. We have finalising our national HSE Open Disclosure Policy. As you can imagine, we've obviously had to look at what's the national developments, not just the Patient Safety Act, but also the National Open Disclosure Framework. We've done quite a lot of research in terms of patient service user experience, and have learned as well around staff experiences around open disclosure, which has informed the kind of review of the open disclosure policy. So we will be sending that out to consultation, and we very much welcome your feedback and thoughts with regards to that revision. The role of the designated person. So for anybody who is not on our mailing list for our newsletter, the team have been very busy, and much gratitude to Catherine Hand and the working group she facilitated and led out on in terms of developing an e-learning program on the designated person. That is available now on HSE land. So we know there are certain services that already have persons working in that role, and others that are still looking at modelling that, how that's going to look in terms of the operational services. But it is an important role, it's a requirement by law. So this e-learning program is really for those people who will be taking on that role, and even for managers to kind of get an understanding of what the ask is of those staff. You will find that on HSE land. And as ever, we obviously want to encourage you to do your open disclosure training. You know it's mandated across the HSE, which I think only echoes the emphasis the organisation puts on the importance of open disclosure. So Module 1 is obviously mandated for all our staff. Next slide. And Module 2 is relevant for any staff who might be required to do open disclosures, so clinicians, some of the senior managers, senior nurses. whatever your role may be. So it really gives you a guide in terms of applying the principles to practice, in terms of having some of those conversations. All our courses are CPD accredited, of course. Next slide. And we very much welcome your feedback and evaluation of the webinar. We feel there will be a part 4 to this, given some of our slight challenges today, and obviously we do want to touch on the maternity ones in the near future. And if you have any other questions or queries, please don't hesitate to get in touch with us. We really appreciate you joining us today. Okay, have a lovely day. Thank you.